Well, welcome everyone. This is the first of our series of lectures celebrating the 20th anniversary of Lucile Packard Children's Hospital. I don't know, were many of you around 20 years ago at the hospital's opening? A few people, maybe? Yeah, you were, right? Dr. Hintz was here, I was as well. And it's hard for us to believe that it's been 20 years already. And this year we're celebrating our birthday in a number of ways. This anniversary lecture series is for our community, focused on many of the innovations that have happened in the past 20 years and what's to come in the next 20 years here at Lucile Packard Children's Hospital. So we thank you for coming to take advantage of the first of our lectures, which is Innovations in Prenatal Care, featuring Dr. Susan Hintz and Dr. Deirdre Lyell, talking about the Center for Fetal and Maternal Health here at Packard. If you picked up a flyer as you came in the door, any of the flyers for the anniversary, you will see on the reverse side we have the list of the upcoming lectures. In February, we're going to be talking about eating disorders and the athlete's triad. In March, we're going to be talking about minimally invasive pediatric surgery with Dr. Duda, who's a fantastic speaker. In April, we have an autism conference for families and professionals. And then in May, we have Dr. Atul Butte, who's going to be talking about the future and personalized healthcare. So we hope you can take advantage of all of them. We are taping this program this evening, and hopefully you'll be able to share it with friends on our website as well. So I'm very happy to have you all here today. I'm Nancy Sanchez. I manage community relations here at Packard Children's, and I'm very pleased to present this lecture series. Well, I'd like to introduce our physician speakers this evening. Our first speaker will be Dr. Susan Hintz, and Dr. Hintz is the director of the Center for Fetal and Maternal Health here at Lucile Packard Children's Hospital. She's an associate professor of pediatrics in the Division of Neonatal and Developmental Medicine at Stanford University School of Medicine, and she's a principal investigator for neurodevelopmental follow-up at the Stanford site of the National Institute of Child Health and Human Development Neonatal Research Network. As a neonatologist, she cares for the most critically ill term and preterm infants who are challenged with an enormous range of complex medical and surgical conditions. Her research focuses on the epidemiology of mortality and short-term morbidities, as well as the long-term neurodevelopmental outcomes of extremely high-risk infants. She also investigates advanced neuroimaging techniques, and she's going to tell you about that, to predict neurosensory and cognitive outcomes. And Dr. Hintz is an Arlene and Pete Harbin Endowed Faculty Scholar. Now, joining Dr. Hintz is Dr. Deirdre Lyell. Dr. Lyell is an associate professor of maternal fetal medicine at Lucile Packard Children's Hospital at Stanford, and she's a medical director for the Center of Placental Disorders. She specializes in caring for women with a wide range of maternal and fetal-based high-risk pregnancies and in prenatal diagnosis of anomalies through ultrasound, amniocentesis, and CVS. Her current research interests involve prematurity prevention, the effects of magnesium sulfate on the newborn, and prevention of complications at cesarean delivery. In addition, she supervises residents in obstetrics and gynecology and fellows in maternal fetal medicine. And currently, she serves as the associate director of the Fellowship in Maternal Fetal Medicine. We have some esteemed physicians here for you this evening, and we'd like to thank them for sharing their time with us. I'd like to begin by introducing Dr. Hintz. Thanks, Dr. Hintz.
All right, well. Thank you very much for that very nice introduction, and thank you all for coming today for the first 20th anniversary lecture at Packard Children's Hospital. I'm really privileged and excited to talk to you tonight about the Center for Fetal and Maternal Health at Packard Children's. This is a multidisciplinary program developed over several years and launched formally 2 years ago with the goal of providing the best comprehensive and coordinated care to complex fetal patients, expectant mothers, and families. This is truly a team effort with maternal fetal medicine, our high-risk obstetricians, neonatology, genetics, medical social work, and virtually every medical and surgical pediatric subspecialty at Packard Children's Hospital as part of this team. I'm also thrilled that Dr. Lyell will be talking about the Center for Placental Disorders, which encompasses a critical and growing concern in pregnancy. So by way of an overview, we're first going to be talking about what is the need for a center for fetal and maternal health, and what can we offer families here at Packard Children's Hospital. How does this process work? How do we provide coordinated and comprehensive care for these fetal patients? Dr. Lyell will then talk about the Center for Placental Disorders, and then we will illustrate the process of the center by going over a couple of cases, and we'll end with looking at the growth of the center, the complexity of patients we see, and the challenges for the future. Well, when a woman learns that she's pregnant, this is often one of the most joyful moments in her life. For these women and families, the knowledge that a baby is on the way is the culmination of hopes and dreams, and often sometimes after years of anticipation. They look forward to planning for the future, to building a family, and most importantly, they hope for a normal delivery and for the birth of a happy, healthy baby. But imagine another scenario. An expectant mother learns maybe after months of pregnancy that she is going to be expecting a baby that could be born with a serious problem. The mother and family immediately have many, many questions. How significant is the problem? Are there other problems? And what will it mean for the future and for the rest of her pregnancy? Will my baby need special care right away? And who will be providing that special care? For both the mother and for the primary obstetrician, the questions go to how can the care be coordinated for the expectant mother, for the fetus, and for the baby? And how can this family get all the answers they need and a plan in place? Well, several years ago when we first started conversations about the need for a coordinated center, we really asked the question, what could Packard Children's Hospital offer these families in need? And we recognized that Packard was indeed a very special place in a very special position, particularly for a children's hospital, that we were able to really offer families a true continuum of care from pregnancy, fetal life, through follow-up. We had under one roof the expertise of the Johnson Center for Pregnancy and Newborn Services with general and high-risk OB, neonatology, and genetics, with the delivery suites literally steps away from the highest level of neonatal intensive care that can be provided. We had experts in fetal and pediatric imaging, all of the medical and surgical subspecialties that were required, an experienced and empathetic medical social worker team, and already established close communications with primary care providers in the community. But without an organized process, how could this possibly work? Well, even in a place like Packard at that time where there were all of these resources and expertise, fetal referrals may have come in through many different avenues to many different subspecialties. And even though we all wanted to communicate, sometimes that process was quite disjointed and certainly far from organized. This kind of communication was generally ad hoc, and in terms of what it provided for the family, it was confusing. This did not result in optimal care for the family, for the expectant mother, or for the fetus that had complex anomalies. So a framework and an organized process really was needed. Particularly in very complex cases where input from multiple specialists is needed, communication is key, and it's crucial to providing the best care for the mother and the baby. Without this kind of communication, there can't be a unified process, and there can't be a unified evidence-based message to provide for the families. And you know, the great thing is that from the very start of our conversations, the entire group recognized the need for this kind of a process. And there was really complete commitment from all of the groups that you see here. And these people continue to be integrally involved in the day-to-day workings of the Center for Fetal and Maternal Health. So what is our mission? Our mission is fairly simple in the center. It is to provide outstanding individualized care and coordination for fetal patients with complex problems and expectant mothers through a collaborative approach among all care providers and subspecialty services, while all the time providing families the support they need through what can be a very significant time of crisis for them. The structure of the center also provides a framework to allow us to share our understanding and our recognition of what happens in these complex fetal cases, which can be rare, with the rest of the community. So who are the patients that we serve in this center? What is the extent of the challenge for complex fetal care? Well, many folks tend to think first of the most complex patients, those infants who are going to require intensive care from the moment of delivery, and in some cases may require surgery very soon after delivery. Some of these very severe anomalies also need very closely and coordinated delivery processes that would include maternal fetal medicine and many other subspecialists to be in the delivery room. And with the significant improvements in perinatal and neonatal management and survival, there is really more that we can offer these families, although again, we need to do this in a very coordinated, collaborative way. This is a picture, and I'll be showing you many pictures, and this is a fetal MRI. This is an MRI that was done of the mother showing the fetus. If you can imagine, this is a baby on side, the brain is up here, there's an arm, and this mass here is right at the neck, called a cervical teratoma. This can cause a significant airway obstruction for the baby once the baby is born, and really prevent adequate airway for the child to be able to breathe. So when we see that, we think immediately that we need to create a specialized delivery process for that woman. When the baby is inside, the mother is taking care of the baby through the placenta by the life cord of the umbilical cord. But once the baby comes out, there can be significant breathing problems that can even lead to death. So this is a picture, and this really only shows about a third of the people that are in a room when there is this kind of a procedure needed called an exit procedure, ex utero intrapartum treatment. And basically what this is a very specialized cesarean section where with maternal fetal medicine specialists working with obstetric anesthesiologists, neonatology in the room, pediatric anesthesia, ENT, surgery, that the baby is partially delivered, still connected to the placental support, while we obtain an airway either by putting a tube in the mouth, or in some cases the surgeons actually have to remove the mass to be able to put a tracheostomy in. Now, that is a very significant type of a case, but I think it illustrates how important it is to have every member of the team be able to provide counseling with the family in advance, for the mother to understand what the risks are to her, and for the family to be prepared for what is going to unfold later. But that is just one aspect of what we see in the center. Patients with so-called minor fetal anomalies are also seen by us and referred to us frequently. These are infants who will most likely not require intensive care initially, but certainly has something going on that is going to need to have care provided and follow-up provided to the child and to the family. This is an example. This is an ultrasound done by one of our maternal fetal medicine specialists. This is kind of the back of the baby, and this is the kidney. It's a little bit harder to see than the fetal MRI. But you can see there is a dark area here that's really a collection of fluid that shouldn't be there. This is called a dilated renal pelvis. In this particular case, there was just that finding along with the dilated ureter, or the tube that drains the urine from the kidney to the bladder. The other side was normal. The rest of the baby was normal. Everything else was fine. So in coordination with high-risk OB, the primary obstetrician, with input from neonatology, pediatric urology, that mother's pregnancy was followed, and she was actually able to deliver at her primary hospital with follow-up already planned and a care for plan already in place, given the prenatal consultations that she had. This is another such example. This is the another fetal MRI. Again, this is sort of the baby's back to you with the head down, so you can't see that. This is the baby's tush. And this is the left lung, the right lung. And what you see here, this triangle upright, is a mass called congenital pulmonary airway malformation. Now, this looks very scary, but actually the vast majority of these masses either get smaller or stay the same while the baby grows. And the vast majority do not cause problems for the child when the baby is born. But again, this is kind of a case where there needs to be a multidisciplinary follow-up during the pregnancy and a plan put in place for what needs to happen for the baby later after delivery. And that's indeed what happened in this case. The mother was able to deliver at her local hospital with a plan already in place and a good understanding of what to expect. But this is really only the tip of the iceberg, because we also have, as Dr. Lyell will talk to you about, fetal problems that are linked to primary maternal conditions. We are seeing a population of high-risk women now who are pregnant, who probably could not have been pregnant a couple of decades ago. And we are seeing women that our maternal fetal medicine team is following with severe autoimmune diseases, with incompatibilities with the fetal blood type, and even women who are being treated for cancers during their pregnancy. So again, this is a case where the entire team really needs to weigh in on what is the best course of management for the patient, and to be able to counsel the family wisely. So how do we, in this center that we've developed now, really provide coordinated care? How does it work? Well, what we have found is that the critical component to the center working is a single point of entry. And this is through our Center for Fetal and Maternal Health coordinators, who I will introduce to you by picture later on. This really provides a clear pathway, a central clearinghouse, if you will, for the follow-up, for the imaging needed, for all of these committed subspecialists to give input and weigh in on what is going to be happening for the rest of the pregnancy and make plans for the future. There, as I said, a commitment to the process. There is at least one person from all of those subspecialties that I talked about identified who is on point for complex fetal issues. And particularly in the case of neonatology, maternal fetal medicine, genetics, there are more than one person on point for that. This has really provided enhanced communication internally, and also with referring physicians and primary OBs, and most importantly, with the expectant mother and family. We believe this has really provided an opportunity to optimize care coordination for the expectant mother and for the family. So now referrals from complex fetal patients come to the Center for Fetal and Maternal Health, but they may come from a variety of avenues. They may come directly from a community OB or from another subspecialist, a local cardiologist who has a case. But most often, these referrals come first to one of Packard's perinatal diagnostic centers. And this is a picture of Dr. Jane Chue, who happens to be in the audience, who is the director of the Packard Children's Hospital Perinatal Diagnostic Center. The perinatal diagnostic centers are places where women have high-level ultrasounds, 3D ultrasounds, and some diagnostic procedures as well with our maternal fetal medicine specialists. This is Yasser El-Sayed, who's the Associate Chief of the Division of Maternal Fetal Medicine. And I think what I want to emphasize to you here is that Packard has built a network of perinatal diagnostic centers in the Bay Area and beyond. So really, women who are identified with issues like this can have follow-up closer to home. Salinas, Santa Cruz, Fremont, Mountain View, they're all staffed by the Stanford Maternal Fetal Medicine team and by Packard genetic counselors. So whether the referral comes directly internally or from the outside, these referrals come directly now to the Center for Fetal Health coordinators, our single point of entry, with first intake procedures done there. And I do want to introduce you to our fantastic coordinators. This is Meg Homeyer, who's our patient care coordinator. She's also a genetic counselor and has been here for years. Stephanie Nevis, who's our administrative coordinator, is fantastic and really pays very close attention to trying to make the multiple appointments that are needed work well for the family. Rather than having to come back multiple times at multiple days, we really try to coordinate all of these appointments together. The case may come in and be quite clear. It may be quite obvious what kind of consultations need to be set up, what kind of conversations need to happen. But in other very more complex or of the moment cases, cases that are very close to term, it may be that we immediately have to pull together with the point people from different subspecialties and immediately put together a plan for that patient. And how do we immediately put together this plan? Well, as I said, we have point people from many subspecialties. This is actually a group of our pediatric and fetal imaging specialists. This is Dr. Richard Barth, who is a world-renowned fetal and pediatric imaging specialist, and we're very lucky to have him as an integral part of the center. Dr. Patrick Barnes and Kristen Yum are also expert pediatric neuroradiologists and have a great expertise on the fetal brain. About 20% of our patients have part of their issue or primary issue as a cardiac issue, and Dr. Teresa Tacey is the director of fetal cardiology at the Children's Heart Center, and she and her team work integrally in the Center for Fetal and Maternal Health. About a quarter of our patients are at some time, it may be within hours, days, or months, going to need the care of a pediatric general surgeon. And this is a picture of our pediatric general surgery team. They are also a critical component of the center. Many of our fetal patients have neurologic abnormalities. They may have malformations or they may have surgical issues of the brain or the spine, like spina bifida. This is Dr. Jin Han, who is our primary fetal and pediatric neurologist who works with the center. And this is a picture of the pediatric neurosurgery team led by Dr. Mike Edwards, and they are critical to the consultations prenatally as well. And again, I just want to underscore the great importance of our medical social work team. Without these folks who are helping families through this very difficult time, and particularly the care that they give to the families that are living from a distance who may need to come, stay here for a period of time, and actually these are the folks that help them find where they are going to stay. We are lucky enough to have the Ronald McDonald House nearby, but we're also very lucky to have folks who have worked on a program called Hotels with the Heart, Erin Champion and others. And with those kinds of resources, we are able to provide excellent care for these families. So this upfront process really allows for timely and comprehensive input and discussion from the whole team. We have regular fetal case conferences at an early hour on Friday mornings, and we are able to review many of the cases that way, but sometimes we actually have to get together and review before those regular case discussions. We are able to review all the imaging in those case conferences, and we also have monthly educational conferences for the whole team. The family consultations, by virtue of the fact that there's been so much communication, we believe is really much clearer. The family gets a consistent message because we have all discussed what the best plan is for the patient, and we are able to provide feedback and really work collaboratively with the primary obstetrician. And we do believe that this has really contributed to a better coordinated care for our families. This is just a picture of one of our fetal case conferences that we have on Friday mornings. And with that, what I'd like to do is introduce Dr. Deirdre Lyell, who is a great colleague of mine, who is the Center for Placental Disorders Director. And when, after Dr. Lyell has discussed about the center, I'll be coming back to talk about some cases and other things.
Great. I'd also like to thank Dr. Hintz for that really nice overview. And also introduction, and thank you all for coming out tonight. I think this is going to be a very exciting series put together by Packard Community Relations, and I think there's so much that we all know about who work at Packard on a day-to-day basis, and I think it's really great that the community knows a little bit more about what goes on here and what's really available as well. So the major focus so far of the evening has really been the fetal aspect of the Center for Fetal and Maternal Health. I'm going to switch over now to some aspects of the maternal focus of the center and really talk about the Center for Placental Disorders. We started with a very clear goal of also streamlining very complex maternal care to achieve a safe delivery for both mothers and newborns. And I think many of you might be asking yourselves, well, what is a placental disorder? First, before I get into that, I just want to give you some background and an overview and a little basic anatomy lesson. This is a uterus or womb. This is what houses the baby. This area is the cervix. This is the part that when a woman has a vaginal birth dilates in labor. Over here is a placenta. Normally a uterus has only one placenta for purposes of illustrating the different conditions. There are 4 here, but typically there's 1 per baby, and we're going to assume we're talking about a singleton, so not quads. In a normal placenta, there's a layer that intervenes between the placenta and the uterine wall. And this allows, once the baby is delivered, for the placenta, also known as the afterbirth, to detach and deliver. And it leaves a very vascular or bloody placental bed. And what the uterus needs to do then is just really clamp down and contract and stop the bleeding. And when things go awry in this process, this can be the reason why worldwide, maternal hemorrhage is one of the major causes in many countries, the leading cause of maternal death. If the uterus really can't clamp down properly and stop that bleeding, then it can go on and really be quite heavy. Normally in a non-pregnant woman, only 4% of a woman's blood supply at any time goes to her uterus versus 20% during pregnancy. So you can imagine how quickly one can bleed really quite heavily. The process can go, let me back up to the function of the placenta is really critical. It's one of the most basic organs to the fetus as it grows. It's what is connecting mom to the fetus and providing all the oxygen and nutrients. And it does many other things that would be outside the purpose of this talk. But what can happen when the placental attachment is abnormal is, in this case, the accreta. This is where the placenta is actually attached directly to the uterine wall. There's no intervening layer here. And what this means is that placenta is going to be somewhat stuck or glued to that wall. It's not going to come out easily. Or in some cases, it's going to come out partially, and then there will be pieces of placenta still embedded in the wall, and this can lead to pretty significant life-threatening hemorrhage. This is an increta. This is where the placenta has actually begun to invade the wall. And this is a percreta, the least common but the most worrisome complication. This is where the placenta has gone all the way through the wall, and it actually can invade surrounding organs, most commonly the woman's bladder, but sometimes it can be attached to bowel and other organs as well. Now, this is an example of what we're talking about. This is a uterus, this entire area here. There's a baby still inside. This happens to be at a cesarean delivery. This is a woman who was known beforehand to have a higher risk of having a placenta percreta. That means the placenta has grown through the uterine wall. And this is actually what they are seeing. This area really shouldn't be this dark. This is placental tissue that's coming through. And in this case, it had invaded to the bladder. This is actually an incredibly dangerous situation. These vessels are really quite engorged. They're several-fold bigger than normal. And so surgically, to deliver the baby, to deliver the placenta in a safe way really takes a lot of complex surgery, need for a blood bank, for massive blood transfusion in order to really sustain the woman to get her through the situation. In this case, the surgeons would make an incision high on the uterus, deliver the baby, and then actually move toward a hysterectomy because you can't leave that placenta in place. The consequences of the placental disorders that I'm talking about are really quite severe. During pregnancy, they can lead to growth problems of the baby. They can lead to vaginal bleeding during the pregnancy. At the time of delivery, though, that's one of the more worrisome times. It can lead, as I mentioned, to acute and life-threatening bleeding, either at the time of attempted placental removal or even after surgery. These women can have damage to surrounding organs in order to try to get the placenta or the vascular tissue out safely, hysterectomy, and in some cases, death. Luckily, we can make this diagnosis often during a woman's pregnancy. Most women these days get an ultrasound to check the anatomy of the baby around 18 to 20 weeks. And as part of routine care, we always look at the placenta. We look at it for many different conditions, including its location, make sure it's not what's called a placenta previa or covering the cervix. And we also look for the quality of the placenta. And if we see signs like this, these are multiple placental lakes in such a pattern that it is suggestive of a placenta accreta, we start to do additional studies, such as Doppler studies. That's blood flow studies. And in this case, this is a vessel that shouldn't be here. This is the woman's bladder. And there's a placenta that is actually, it is a percreta, and it has grown abnormally through the wall and toward the bladder. If there's any question and we're not clear on what's exactly going on and we need better data, we'll also get an MRI. But we also consider what is a woman's a priori risk. We have other clues as to whether or not she might be at risk for having a placenta percreta or an accreta. We know that the number one risk factor for having a placental condition that I've mentioned is having a prior uterine surgery. The number one uterine surgery in this country, actually and worldwide these days, is a prior cesarean delivery. So if a woman's had just one cesarean delivery, she has a 0.3% risk in general of having a placental problem such as an accreta. If she has what's called a placenta previa, meaning the placenta itself is covering the cervix, the part that dilates, then that risk actually jumps up to 11%. So when we do our ultrasound and prenatal diagnosis, if we know that there's a previa or we know that somebody's had multiple prior cesareans, we are extra aware of this potential condition. We're always looking for it, but these are women who certainly merit more studies, and we really need to, the rule is to absolutely rule it out. After 2 cesarean deliveries, the background risk for any woman is about 0.6%, but it goes to 40% if there's a placenta previa. And after 3 cesareans, these numbers jump to 2.4% risk for having an accreta, or 61% if there's a previa. So very, very high a priori risk. We know that other risk factors are conditions that cause scarring along the uterine wall, Asherman syndrome, and then finally fibroids that are lining the uterus, just in a level called submucous fibroids. Now, unfortunately, the incidence of placental disorders is really increasing, and this is part of what prompted the development of our center, because we really did see the need. The reason it's increasing is directly correlated to the cesarean delivery rate. If you look at the lower left-hand corner, this is the rate of cesarean deliveries in this country in the 1960s. It was about 5%. And I think it's fascinating to note that in 2007, it was almost 32%. And unfortunately, we are only seeing a rise in this rate. This is not falling. This is of all births in the United States. So that means that far more than 1 million births a year in the US are happening by cesarean delivery. This is also happening worldwide. Actually, in many countries, the rate is much higher. So in order to achieve a safe delivery, as I've mentioned, it requires expertise from multiple services, and this is a list of the services that are typically involved. Maternal fetal medicine, that's my division. We are primarily there initially for the diagnosis of the problem, for delivery planning, and actually achieving the delivery itself, and helping with coordination of care. Our obstetric anesthesia colleagues are really quite critical in this situation. In addition to providing anesthesia, they provide critical care support in the operating room. Gynecologic oncology might sound funny here. Why would an oncologist be involved with a placental disorder? Well, they are really the experts in very deep and very complicated pelvic surgery. And in these abnormal placental conditions, we know that you can have very significant vascular invasion and vascularity in areas of the pelvis that really only someone who's very comfortable in these very deep pelvic spaces should operate. So they are, lucky for us, available 24/7. They assist us in all of these deliveries, and they have been absolutely critical. And this is what's going on around much of the country as well. Our pediatric radiology colleagues help us also with the diagnosis, either through ultrasound or they're the ones who really read the MRIs. We sometimes involve interventional radiology, not routinely, but that can be very helpful as well. Women who have these deliveries most frequently go to the intensive care unit after delivery for recovery, at least for 1 or 2 days. Our neonatal intensive care unit colleagues are critical as well. Some of these babies are born prematurely if a woman is bleeding, and we need to intervene to deliver to keep mom safe. But also all of these deliveries that happen in the main operating room, and at any cesarean delivery, our neonatology colleagues are there. Transfusion services have been utterly life-saving in this, they've saved lives. The reason that many of our community doctors have referred their patients here to our center is that we have such an amazing ability to give massive amounts of blood very quickly. We also are very grateful to the perinatal nurses. They help to take care of these women before delivery and after. You know, if you are recovering from a cesarean delivery in the intensive care unit, it's nice to have a postpartum nurse come over. You're no longer on maternity, so they can provide special maternity support, and they do. And then finally, our pathologists, we have some experts in placental pathology here, and they help to confirm diagnoses and really kind of identify the extent of the diagnosis after the fact. So our goals of the center have always been very clear: to minimize the morbidity and mortality for the mother and the newborn, to maximize coordination of care, and then to research the problem of abnormal placentation. This is our team. I'm the director. Other members, Dr. Al-Sayed, the associate division chief, whose picture you saw earlier. We have a research nurse, Elizabeth Koget, Elizabeth Langen, our fellow, and then also Meg Homeyer and Stephanie Nevis help a lot with intake and coordination. And then Dr. Susan Hintz, who is the director of the overall center, has been always very gracious to share resources and really to allow us to get this off the ground. So I'm extremely grateful to her. We also have ancillary team representatives from all of these services, many of which I've already mentioned, but also representatives from the Stanford operating room, because unlike our routine deliveries that happen on labor and delivery in the Johnson Center, all of these women deliver over in the Stanford main operating room. Referrals are usually physician initiated, and this is the number, but we've had referrals come directly from patients as well, women who have wanted second opinions, for example. And once a woman's referred, she gets an ultrasound with us, an MRI only if that's indicated. If we are concerned about a placenta percreta, meaning it's grown through the bladder, through the uterine wall, we will typically get the MRI. She undergoes consultation with our service, maternal fetal medicine, and then possibly with other services as well. And then we coordinate the care and start to assemble the team. There's always a decision about whether or not these women should be inpatient or outpatient. That depends on whether someone lives far or near. We recently took care of a woman from Salinas who had many transportation issues. It would be very difficult for her to get anywhere in an emergent situation, so we actually hospitalized her quite early. But if women bleed or have any complications during pregnancy, certainly we get them into the hospital and would rather watch them, keep them here until the delivery. But we then assist with the delivery planning with the patient and her family, but also through a multidisciplinary team process as well. And everyone I've mentioned ultimately assists in some aspect of the delivery and the patient. And we really don't consider our job done until we have a healthy mom and a healthy baby who is then reunited with her family. And thank you. I'm happy to take questions at the end.
Thanks, Deirdre. That was really beautiful. So just to illustrate, I think Deirdre did a great job of illustrating the maternal side of things, and I think what we're going to try to do now is just use a couple of cases, and there are, of course, many, many cases from these programs to kind of show how the Center for Fetal and Maternal Health works. So I'm just going to start by telling you about a woman who was referred to the center at 22 weeks gestation, and this is, again, when a full-term baby is born. That's usually around 40 weeks. So this is very early in the pregnancy. and was referred by an obstetrician to one of the regional Johnson Center perinatal diagnostic centers with a concern for something called an omphalocele in the fetus. And what is an omphalocele? This is a picture, just a cartoon of a child who has omphalocele. This is when abdominal organs actually extrude outside of the body at the base of the umbilicus and covered only by a membrane. A giant omphalocele is generally called that when it is a very large defect or when the liver is out. These are fairly rare phenomena, about 1 in 4,000 to 1 in 7,000 live births. But of course, we tend to see many of these patients because they tend to be referred from our maternal fetal medicine colleagues into the Center for Fetal and Maternal Health for comprehensive care by the full team. Some of the issues here are that 30 to 60% of these infants may have other kinds of problems. They may have heart defects, or this may be part of a syndrome. And so it's very important that these pregnancies are carefully evaluated and that the fetus is carefully evaluated for other potential problems. In the case of very large defects, the babies can have very significant respiratory problems and can have long-term feeding problems and other issues, which I will touch on in just a bit. So back to this case, this woman did have genetic counseling, as do all of our cases at the Perinatal Diagnostic Center. An amniocentesis was performed by one of our MFM colleagues, and that was normal, which was good news. A fetal echocardiogram was done at the Children's Heart Center here at Packard, and that was normal. So the heart of the baby looked normal and had normal structure. A fetal MRI was also performed here at Packard to further delineate this problem. And there were, of course, high-risk OB, pediatric surgery, and neonatology consultations as part of our multidisciplinary approach. This is a fetal MRI again with the baby. You can see the baby on the edge, kind of on the side. Here, you can see that this is the baby's brain, kind of on side, and this area coming out here is the omphalocele, and actually what's seen mostly here is liver. The important thing to talk about next is how is it that the center and the combination of the subspecialists and the coordination and communication between us help this family to understand the process. Well, in this particular case, giant omphalocele and omphalocele in general, the approach to babies with that problem has changed quite a bit over the years. It used to be that the thought was rush the baby into the operating room, try to put all of the contents from outside inside, try to close that wound, and get the baby into the intensive care nursery. Well, as you can imagine, that doesn't always work so well. There's a limited space where all of the bowel and other organs have been outside the body. These babies can have very significant respiratory problems after such a surgery with all of that content suddenly in the small abdomen. They can have problems with the actual surgical incision. They can have significant problems with infection, with feeding issues, and they can have a very prolonged hospitalization. Now, frequently, again, through research and through an understanding of what the natural history of this process is, we now institute frequently a non-surgical initial approach. And this is basically compression bandages over a period of time that the family can learn, and eventually the baby would be able to go home earlier. And this is obviously a coordinated process that requires multiple disciplines to work together with the family. And it's very important that prenatally the family understands what the possibilities are, what the likelihood of success could be, what the other alternate outcomes could be, and for the maternal fetal medicine and OB colleagues to understand the process as well, so this family can get a consistent, clear message. And as Nancy told you earlier, you'll be hearing from Dr. Sanj Dutta if you come back to any of the other lectures, and he's going to be talking about minimally invasive surgery. So this is a patient Her name is Ava. Her parents gave me many pictures of her. She came through, her family came through our center, and she had the diagnosis of a giant omphalocele prenatally. She went through all of the consultations and discussions that we just talked about, and this is just a picture of some of those compression dressings that happen. Of course, first in the neonatal intensive care unit with careful monitoring of the baby, training the family about these compression dressings, a custom-made silo here is kind of a foam core silo that is placed, and the parents learn how to do these kinds of dressings. Now, it's not that the baby comes out and the baby goes home the next day. The baby is in the hospital, in the intensive care unit, sometimes for weeks before a baby is ready to go home with these issues. But in Ava's case, she was very fortunate that she was able to learn to feed quite well. She didn't have many problems with feeding. Her parents were very motivated to learn about these dressings. And she went home in about 2.5 weeks with close follow-up as an outpatient with the pediatric surgery team and with the pediatric surgery nurse practitioner, Claire Abrahano. Now, I do want to say this is not always the way that it works. Some children have very significant problems that really don't respond as well as Ava's. But in her case, it did work. And this is actually some follow-up pictures as an outpatient. This is Ava at 8 weeks old. And you can see she still has kind of a bulbous tummy, and her defect here is still visible, but this is all continuing the process of her compression dressings. This is at 15 weeks old, and I think you'll agree that it's fairly amazing that that is what she looks like at 15 weeks. I saw her recently at the beginning of January in a follow-up appointment. I'm sorry, I didn't have a great shot of her belly, but I'll tell you it looks even better than it did at 15 weeks. She's obviously a very happy, healthy baby here, and her parents have done a fantastic job with her. The second case, and as I said, I have so many cases, but I just have time to share 2 with you. This is a case of a metabolic disease. An expectant mother was referred to our MFM group and to our metabolic genetics group, led by Dr. Greg Enns, because she was carrying a male fetus and had a history of having had a previous son who died very early in infancy, and she herself had male siblings who died very early in infancy. This story and some other information that was gained made our metabolic genetics team very suspicious for a rare metabolic disease. Further testing was recommended. Our MFM team carried out that testing by getting some blood from the mother and also doing an amniocentesis, and was found that the mother was a carrier of this problem by her blood test, and furthermore that the mutation analysis done by the amniocentesis was diagnostic for this problem in the baby. Now, this is a long name. It's called ornithine transcarbamylase deficiency. It is very rare, about 1 in 80,000 births. And the reason why I emphasized to you that it was a male baby is because this metabolic condition is called an X-linked recessive disorder. Now, I'm not a geneticist, but I'm sure most of you understand that what the chromosomes are basically paired sets of instructions, blueprints for telling the body what to do, how to make proteins, how to make enzymes that help your body metabolize things, grow, and develop. If you're a woman and you have two X chromosomes and this particular problem where there is a misinformation on one of the chromosomes, which is an X chromosome, if you're a girl, you have another set. You have another X chromosome. You basically have a backup copy. And even if there's a set of instructions that's abnormal on that one X chromosome, the second X chromosome will be able to provide the information correctly. If you're a boy, you have an X chromosome and a Y chromosome. And if you inherit that X chromosome with the misinformation, you don't have a backup copy. And all your body understands is to make either no enzyme that's required or a wrong kind of enzyme. Unfortunately, for this kind of metabolic condition, if you don't have that enzyme, it can lead rapidly to an inability to process your proteins normally. And so you get a buildup in a waste product called ammonia that can't be gotten rid of. And if you don't know that that's the problem, this can lead rapidly to brain injury and even to death in the baby. So this was really a great thing that we were able to know this in advance. We were able then to coordinate the metabolic genetics, MFM teams, and neonatology teams all together to implement some novel treatments and also implement immediate therapy for the baby, which is almost unheard of, really, unless you have that knowledge that a mutation exists. This mother, during labor, with the help of our MFM team, and it was Dr. Yair Blumenfeld, who was the lead MFM on this case, gave the mother treatment that was basically pre-treating the baby. So the baby had some medication on board when the baby was born. Immediately, the baby came to the neonatal intensive care unit, where we had already set up a very specific nutritional plan, as well as a medication plan for the baby with the input of the metabolic geneticist. And I think the important thing here is that because we had all this coordinated information in advance, we were able to keep this baby metabolically stable, which is, again, quite rare to be able to do for a case that can be this serious. And we were luckily able, it seems, to be able to protect this baby's brain and body. And in fact, this baby had a successful liver transplant, which is curative for this condition, in March of 2010. And speaking with Dr. Enns recently, the child, thank goodness, is still doing very well. So those are just two cases that kind of illustrate the multidisciplinary process that we go through. And I also want to just introduce you to how our program has grown, what kind of complexity we see, and what kind of challenges we have for the future. Well, as I said, we formally launched this multidisciplinary center about 2 years ago. And as you can see from the blue line here, we have continued to have increasing referrals month over month during those 2 years. And what all these numbers mean is that we have been privileged to be a part of the lives of over 220 families this past year, and hopefully be able to help them through a time of significant crisis. The number of cases that are referred to us really continue to increase, and we really hope that we are going to be able to continue the process of helping these families. The complexity of the cases that are referred to the Center for Fetal and Maternal Health is quite high. About 90% of our patients require 3 or more medical consults and or imaging appointments from our initial intake. And that's just kind of the beginning, because most of these patients require multiple follow-ups. We really try very hard to work with the primary OB and with the regional perinatal diagnostic centers so that many of these families can get their follow-up closer to home. But some of them, they need to come back multiple times. All of our patients who need to deliver here at Packard, and particularly those who live at a distance, are referred to one of our medical social worker team. And this is really a critical component, as I've emphasized before. They really help families through this very critical time and help to provide a place for them to stay if they live really far away. Due to this complexity, about 80% of the patients that we see in the center need to be delivered at Packard. Geographical referral area is also another significant issue for the center. About 40% of our patients are from greater than 80 miles away, and not only in California, but in states all over the United States. And given that distance, again, just to emphasize, if we have a family that needs to come from 3 to 4 hours away and we need to coordinate 4 or 5 appointments and imaging appointments for them, that means they usually need to have at least an overnight stay, even for that initial time. For our very complex patients, and Dr. Lyell has pointed to at least one group of patients that need to come here closer to the time of delivery. They can't be out at a place that can't provide them either the care that they need for a complex delivery, as with a placental disorder, or the baby, the care that's needed if the baby is expected to be critically ill at the time of delivery. So that's another component of what we are seeing. In terms of just a few bullet points in terms of goals and challenges for the future, as I said, we really recognize that there's an increasing awareness of the need for this kind of program, and we feel very privileged that we are able to be a part of the lives and help more families. But we also recognize that we need to keep up with that duty of helping families. So this is going to be a resource-intensive issue over the next years to come as the numbers increase. In terms of the regional referral pattern, as I said, this is a hardship for the mother and the family. And we recognize that with more and more patients coming in, especially from further away, we really do need to ramp up our family and social supports to keep up with the increasing needs. We feel that we as a group have really enhanced the pre-delivery communication and coordination component, that families understand better what is lying ahead for them. But we feel that we can even enhance the coordination and communication post-delivery and post-discharge. And that's one of our goals for the future. And one of our dearly held goals is that we want to continue to contribute our evolving understanding of some of the very rare cases and the series of fetal problems that we are seeing to contribute to the understanding to the community at large in fetal medicine. And really, as Dr. Lyell knows, this is important not only for understanding these problems on a research level, but also to training the next generation of physician scientists at Stanford so that they can go out and contribute to improvements in fetal care throughout the country. So I would like to thank you for both Dr. Lyell and myself, and for the whole Center for Fetal and Maternal Health. This is actually just a small fraction of all the people that contribute to that. It really is a team effort. And as Deirdre told you, this is the contact information. It's actually also in your handouts, the brochures that you got. And we also have a website at Packard, www.fetalcenter.lpch.org. That website has a lot of internal links to a lot of other specialty programs at Packard, to the NICU, to MFM, and to all the subspecialty programs that you heard about today. So thank you again for your attention. It was really a pleasure to talk with you today. And thank you very much, Nancy.
Thank you so much, Dr. Hintz, Dr. Lyell. This was very inspiring to hear what we have to offer here. Even we who are employed here at the hospital just get so excited when we hear what's going on in the various departments. And we thank you for coming and attending our first anniversary lecture. We look forward to seeing some of you next month when we were talking about the fetus and the newborn here, and we're going to be talking about the other end of childhood, the adolescent athlete. And we have a panel of physicians from our eating disorders clinic coming to speak on the myths around eating disorders and the athlete. So we hope that you might join us then. And again, as I mentioned, as you well know, this presentation has been taped. So if you would like to review, didn't take notes, you'd like to review, we should have it on our website at lpch.org very shortly, and you can tell your friends as well. Colleen Hazeloop, who has helped to coordinate this entire evening, is at the back. Thank you, Colleen. And she will pick up your little evaluation. We'd love to know what you thought and how you found out about the lecture and so forth. It would help us in planning. And lastly, Colleen had some refreshments out there for you. If you didn't pick them up on the way in, please do so on the way out. Have a good evening.